All right. The lights are a lot brighter than I expected. I asked the team to, make sure that my good side was showing, and most of you just get the bald side on this part. So, in addition to the podium. Hey, I'm Steve Posnack. I serve as the deputy for Tom among some of our other colleagues here, many of our colleagues here, I should say. One thing I just wanted to note, if we could have 3 quick claps for Cannon. He is our MC, director of the show, the guy that since we're in award season, the camera cuts to at the middle during a camera break to show all the chaos that's happening. And much like interoperability, if all goes right, you don't see Cannon at all. And that's probably the first time he's been compared to interoperability. But just a quick clap for Cannon. Thanks. Complaints go to Cannon. Compliments go to Tom. Just make sure we keep those things established as well. I did take my ethics training, so our feds can't accept gifts, but you can give them high fives. There's a lot of work that was involved in sessions today, so please thank a Fed, especially our team that's led the creation of a lot of, I think, thoughtful sessions relative to the work that we've got going on. And along those lines, we're here to talk about transparency and affordability. Tom did a great job teeing that up. We jockey for what the most exciting session title would be, as many of you are familiar with, doing events like this. And I was almost thinking of leading a chant with the crowd of, what do we want? Transparency and affordability. When do we want it? Now. We can go outside to the sidewalk later if you'd like during lunch. Want to do quick introductions for everybody, and we'll just go straight down the line. So Cynthia, why don't you kick us off and let us know who you are and what you're up to.
I'm Cynthia Fisher, and I'm founder and chairman of PatientRightsAdvocate.org, and we seek to have full transparency into prices up front, itemized billing, and payment integrity, showing the financial money flows to have integrity to those very prices. Essentially be able to create a functional and competitive market in healthcare, benefiting the consumer to lower costs, have affordability, and have integrity in preventing overcharges, errors, and fraud.
All right, we'll hear about that in a little bit. Jocelyn, please go ahead.
Cynthia might be my new favorite person. Jocelyn Keegan, I work for Aetna. I run our interoperability team, which is part of CVS Health. And I own really the strategy and the execution of how we're trying to simplify and show up for our members and our providers with better tools. And when I look at the work that we're doing, I'm thankful to be here with this group. We're at the tipping point of that becoming possible. I'm a recovering product manager, and prior to joining Aetna about 18 months ago, I ran Da Vinci, which is one of the projects that a lot of the standards development progress that we're making is based upon.
We'll get to that.
So much fun.
Colin, go ahead.
Hey, Colin Vanis. I am an internal medicine physician, still practicing. Currently the chief medical officer for a medication management e-prescribing company called Dr. First. And I am a recovering CMIO. For 17 years, I was at VCU Health as a hospitalist and chief medical information officer during the meaningful use years. And at Dr. First, we're really trying to innovate in the medication management space around transparency and friction.
Sumit.
Hi, everybody. Sumit Nagpal. I'm a serial entrepreneur. Been in what we call digital health for the past 35 years, building my 5th company. With my 5th company, I took a little bit of a detour or a change, approaching the problem from a consumer's perspective rather than a provider or health system perspective. I'm also here representing HIMSS. I'm on the board of HIMSS. I've been on the board for 6 years. And really, thank you for having us.
All right. First question. I feel like it's a game show now at this point. So Tom already covered a lot of our buzzwords. Healthcare loves buzzwords. Transparency, affordability means a lot of different things to a lot of different people, depending on the context. Cynthia, could you give us a sense of what that means to your organization, how it looks, what it looks like in practice?
Well, we know where we want to go. Obviously, and as Sumit said, when you look at the consumer, it's really the consumer who is in great need of having access to the information, to be able to know in advance of care What are they going to have to pay? What are they going to be responsible for if they're covered by an insurance carrier like Aetna or United or Blues, whomever? What is truth? And then to have integrity in billing. Okay, so that having itemized billing under standard format would be great. And then to have the claims payment that is shared with the employer or with the government based upon how the coverage is paid for. But ultimately, let's remember that the true payor is the patient, is the American worker. The American worker pays for all of healthcare, and the American employer out of wages, out of what is take-home pay, and earnings. And yet that consumer is the most ill-informed or non-informed in the healthcare equation. And yet it's the individual, too, who, if we're going to have the best outcomes of care, we need to have the best information we possibly can. So today I would say that the office, I want to thank for sure, the first Trump administration got hospitals and insurance companies to have to post prices, and Biden kept that in the second. And now we're here in the second administration, and applaud Secretary Kennedy and the president for coming out to say it is time for maximum price transparency and maximizing access into accountability into the fees of all the middle players that are capitalizing on the point of patient care. And we have a long way to go because, frankly, there's been a lot of obfuscation. We're 5 years out now, almost 6, right? And there's been a lot of obfuscation, both in the hospital files and in the insurance files, that I believe have a great opportunity to be well overcome. And in today's age, all of you with all your great skills and technology can pull back that curtain and make it happen. And I'm encouraged with the progress and our best friend Mo, which is momentum, to deliver transparency to the consumer.
Awesome. Jocelyn, you got a big footprint of work that you've got to deal with at Aetna, so give us a sense.
Yeah, and I really love the way that you frame that question, because when we look at it, we understand that there's a lot of technical plumbing, right, underneath, and the enablement, and we'll talk a little bit more about the standards later. That's important. But sitting in the seat that I've been in for the last 18 months, that ability to be able to translate like the so what, the impact of simplifying that message inside of these large complex organizations is really important, but also our ability for the consumer and for the provider that's caring for the consumer. Tom's example is great, right? It really is at the point of care, we really want that transparency. We want information equity for a member, for a provider, for a patient. And so we're making investments in that, simplifying that story and making it human readable. We've made massive investments in Aetna Health, our member-facing application. And again, I chose to go work for Aetna because I feel like we're uniquely positioned with the different assets and with partnerships with my colleagues at CVS to really press on that, not just for our members, but for members in general, to be able to take advantage of the emerging standards, to be able to get to that transparency, to be able to understand what actual cost is. And I think as we go into some of the other questions, the shift really of having to have the information in that immediacy to move from what happens today, which is largely retrospective, to more real-time data. The tools are there for us to do it. We're super excited to execute and be able to get that better, cleaner information. For a subset of our commercial clients, we've rolled out a solution this year called Smart Compare that literally allows a member to be able to understand who's in their provider network, the quality of that provider, and what their price point is. So really allows a consumer to drive their own healthcare journey. In many places that you're just not able to do that today. You sort of wait to see what comes through, right, in the bill retrospectively. And so that's really important to us. And we think that the better we can do with information up front to a member and to the provider that's caring for them, that will reduce all of that back-end churn that causes so much distress and waste and anxiety in people's lives today.
Yeah, and Colin, thank you, Justin. And Colin, you operate in a very high volume space. Subtle changes can make a big impact. Can you give us a sense of the affordability and transparency side from your perspective?
Yeah, a couple of things come to mind, and my colleagues here used a couple of words that really resonated with me. Notice they both said information rather than data. It's important that we're not just giving massive XML markup files that are, incomprehensible to the user or to the patient. You really do need the information, and it needs to be contextual, in that real time, as you guys said. And then obfuscation. It's a big word, but it's a good word. Because I think I'm in a unique position where I'm a patient, I'm a doctor, I worked on EHRs and clinical decision support, and now I work at an e-prescribing medication management company. And I still, when prescribing, often cannot figure out the rules. I can't. If you've heard me on any of my podcasts or things like that, I will say, very candidly, we all have better visibility into the Domino's pizza order than we do to a life-saving medication in terms of status, where it is, what it's going to cost, when it's going to arrive, et cetera, et cetera. And there is no reason that this cannot be conquered in the year 2026. The fact that we're still talking about interoperability, back from 2011 meaningful use days, now we've come a long way. I just don't think we go fast enough. And I'm glad to see that I think a lot of the pressure now is coming from the patient side, actually. It's, why can't I have the similar experience that I can in aviation, banking, retail, in healthcare? And so let's keep let's keep the pressure up, because I actually think we're starting to accelerate, and I'm excited.
Great. And Sumit, you've been making investments, you've been starting companies. We were talking earlier, where do you see some of the future work in affordability and transparency?
Yeah, I think everyone's touched on so many of the important points that I was going to make, that I'll focus on exactly to your point, where this is all headed. We've been talking about these topics for 30 plus years. And in some ways, we've made huge progress. In other ways, we're still talking about the same stuff. There's an overlay that's occurring in our economy, and this is not just in the US, it's happening in other parts of the world as well, where there's an entire parallel model emerging outside what we at HIMSS think of as the medical model. The medical model is the episodic, care-based delivery systems that we've all been talking about, that own the information, or at least maintain it, and that consumers sometimes get access to and sometimes not, and that we all struggle with. Around that, at an accelerating pace, is this health model that's emerging, where it started off with concierge services, expensive, folks who could afford it. But then, as those models were refined, as those models were tested, we're starting to see more and more of those emerge for the rest of us. Right? HIMSS believes that this health model that is emerging around how and where we receive care is actually going to have a profound impact on the fluidity of information flow. Right? Consumers are now, exactly as everyone here has said, demanding access to their own stuff the way that we have access to information about our pizza order. And there are companies that are delivering that. And those companies in a free market setting will, in fact, start becoming more valuable and more used. And we think that the markets will also start playing a bigger role in where this goes. Right? So our position really is, our thinking is that the health model can emerge and sort of dominate, or the health model can join up with the medical model, but the health model is happening. And that's where the future is.
Great, thanks. All right, everyone's got a good sense of what's going on. I let the panel drive itself most of the time and just kind of give them a helpful nudge. So Jocelyn, I'm going to go to you first real quick. As Jocelyn disclosed, she was on the, I would say, recipe side of the house, and now you're on the cooking side of the house. So where do you see the most impactful points of change and intervention now? You could focus on Da Vinci, a little bit broader. Right. When it comes to affordability and transparency, how are those things getting implemented in the real world?
Yeah, I would say maybe just simply, right? There is the what you have to do, right? And I think many of us work with folks in the industry that have a compliance mindset. And part of the reason that I made a decision to shift seats, and I like to refer to it as theoretical math, to applied math, is to actually make sure that this stuff gets implemented correctly. Because I consulted for a lot of payers and vendors and provider organizations in my previous life. I think that the promise of where we're trying to get, to Smit's point, we've been talking about this for a long time, we're so close. And that what I really see is a willingness to understand not just like the moral imperative, right, of making sure consumers really can drive their own care and that they have the tools to do that, but is that it's smart business. There's ROI associated with taking all of this waste out, and the tools are there to be able to use it. But change is hard, right? And there's a lot of sort of entrenched sort of players that aren't moving as fast as we need them to move. Sumit, I love your comments, right? Like the market is going to evolve one way or the other, and so from my seat and what I get to do on a day-to-day basis, we're really seeing the ability to use technology as a differentiator in how we deliver, how we simplify for our providers, our members, our own internal teams, and really that power of leveraging technology for its highest best purposes, and not because we have to, but because there's ROI for us, there's value in our NPS score with our providers for it, there's abrasion and better outcomes for our members when they have more access to their information. And these are the things that we should all be running our businesses on a daily basis. And Colin's right, like we are all the consumers here, right? We all have stories about, this is so broken, how is it still broken when we're in the midst of caring for a family member in a really difficult time. And so to me, the tools are there. And the way I look at it, and part of the reason that I made my shift was, to me, it's about execution now, and it's about bringing it to life and driving the storytelling so that we can get to the transparency that we need to have, and the information is in the workflow of choice of the provider or the member. We're not dictating or pushing people to portals to be able to do that, and we're doing that. We're deploying better tools so that people actually can control their healthcare journeys.
And so, Colin, for the real-time prescription benefit related work, you've been involved in that. You've seen it firsthand. How's the experience changed over time for providers, and a little bit of what we can look forward to in that space?
Yeah, I mean, even though I look young, I've been doing this for quite a long time. The fact that we can actually see RTPB transactions within workflow the majority of the time is actually a huge difference. I remember when that was like a pipe dream. And so that's why I sound cynical and say we're not going fast enough, and then you sort of look back and you're like, wow, we actually made a lot of progress in 15 plus years. But there's still, the word trust comes to mind. There's still instances where the providers will not trust the data or the information that's coming back to them, whether it's because that particular RTPB feed doesn't have all of the payers, or it doesn't have a payer, therefore it makes an estimate, and the estimate is way off, and the doctor's been burned by that before, so now they're not even going to look at it. And so there's definitely opportunities to continue to improve and iterate on that simple transaction. There's also, this comes to mind a lot for me, is healthcare is increasingly, actually to me it always has been like a team sport. Nurses, social workers, pharmacists, et cetera. But we still block some of those users, some of those EHR users from actually accessing that information. A lot of the times you can only see an RTPB transaction if you have e-prescribing privileges, or at least the ability to tee it up on behalf of a provider. Well, social worker needs to see what things cost, case manager needs to see those things. And so I think there's little things that we could do in that, just like that could improve it. And I also think improving the trust, improving the data accuracy and the coverage, if you will continue to make a big difference. And then ultimately coupling that with a patient engagement solution that provides the patient the exact same view. I mean, there's no reason that only I, the provider, should be able to see this. The patient equally should be able to see it and make decisions on their behalf as well.
And
the power of APIs. Right?
There you go. Yeah. Maybe we'll get to the tech saving us question in a sec. Cynthia, you see this firsthand with patients every day. The stories that you have help sell policy and advocacy and all that other, kind of helps the narrative. Could you share, from your perspective, some of the maybe most poignant examples that you've got?
Yes, Steve, transparency is truly transformative. And the lights are bright, but I do have to ask, how many of you in your family have experienced an overcharge by our healthcare system?
It's a good amount of hands.
That's a good amount of hands, right? And so this session is about affordability. What we're seeing is price transparency and transparency into billing and payment. What that does is pulling back the curtain, shining that sunlight, and shifts power to the patients. It shifts power to the employers to design better plans to be able to lower the cost of healthcare. And it also, for the first time, gives us prices so that we know whether or not those bills were accurate or not. So look how many of us raised our hands about this situation. And so let me give you a couple of examples at the macro level. Is because of price transparency that you all have done at HHS and Department of Labor and the Treasury to start to pull back the curtain on hospital prices and the insurance prices, even though it's a mess and you have to hire tech firms at a good dollar as another middle player to kind of evaluate it, which we should really be using ChatGPT for comparative prices at this stage. AI should be benefiting the consumer. But that being said, we're learning from lawsuits. So let's go on the macro level what this means on a 20,000 employer plan, self-insured, using an insurance carrier as an intermediary. So that means the employer is taking on the financial risk along with their workers and their families with high deductibles, right? That means the patients and their families are having to dish out. So those prices and accuracy is really important. The employer plan has to sue to get access to the claims data. Why? Why is claims data, why is every receipt not being able to reconcile that checkbook to the actual price? Well, it's because the insurance industry has confiscated that you pay into a trust account and they own the checkbook. And they're hiding that and not allowing audit provisions for integrity in billing. So the employers have come to say, I'm a fiduciary of my spend and we need to get access to the claims, and they've had to sue. So what we found is utilizing the transparency and coverage data, the employer was able to see when they finally sued and years into it got access to the data, they spend $180 million on their annual spend for healthcare for their workers. 30 million of that was overcharged way beyond what the insurance carrier said was the price for those services. Those 30 million out of 180 million were all overcharged. That's 17%. That's huge money when you correlate that across. And that's why we see like Kraft Heinz suing for $1.2 billion, at Aramark suing for $1.6 billion, Ford Motors suing for $1 billion. But come down to the everyday worker, this is hugely impactful, not only from the employer side, but then down to the worker side. So we saw another lawsuit with Johnson & Johnson being sued by the employees for lack of fiduciary duty, and Colin, this was on prescribing. And one of the pieces in the lawsuit said that the MS drug, the employees sued because the every 90-day copay of that drug was $1,725 to the worker to have to pay for that generic MS drug. And the total amount J&J paid and share with that was over $10,000. Now, why is that so expensive? Well, the insurance carrier owned the PBM, the pharmacy benefit manager. The broker was affiliated with them. They get a fee for a conversion to a 90-day fill, maybe a $10 fee to them, plus a fee for the prescribe. And then you've got offshore biosimilars and labelers and all these other entities in between. When the employees were able to look at Walmart or Mark Cuban's Cost Plus Drugs, that same generic drug at Mark Cuban Cost Plus Drugs, cash money, was $28.40 for a 90-day fill. So if we're being fiduciaries to manage money, we need to see all of these prices. And so net, what we've found is at the individual level and across at the macro level with the employers, and look, this is happening in the governments too. The state of New Jersey just filed $100 million worth of fraud that was admitted to by Horizon Blue Cross. Why? Because the hospital for this big cancer care billed $600,000, and $2.5 million was taken out of the state of New Jersey's trust account. Where did all that money go? If we don't have transparency, we can't see it. And the state of New Jersey was locked in to only see 500 claims. Well, they spend almost $6 billion a year. So the only way we can have trust and we can restore trust in this country is to shine the sunlight on all of this and see the wide price variation. And what the hospital price transparency files have shown us is that there's 10 times price variation sometimes in the same hospital for the same care. So for instance, just coming here last night, I got an email. We at Patient Rights Advocate take on anybody who comes to us with a bill that they think is far egregious to what they should have paid, and then we get the data. We have never lost. Every bill has been an overcharge. Every single bill, either by the hospital themselves at the level of coding or the insurance carrier. So what I would say is what we see right now is the opportunity, because at the individual patient level, we just had a hernia repair at George Washington come into us at a $97,000 claim. No complications, didn't even stay for the day. Okay, it was the appendectomy. The appendectomy was done same day, sent home. $97,000. On my way here, I said, what is the lowest price in that hospital file for an appendectomy, clean, no complications? $1,300. Okay? And this was negotiated down to $14,000, and the patient's $4,000 out of pocket. Okay? So stick with me on this. We're trying to...
We're with you.
Okay? But why is that? Why is that charge master? Why did that come out at $97,000? Because I encourage all of you to go to all of your employers and ask if you can read their contract with the insurance carrier. When you see the contract, it will have gag orders in it to not share prices. I'm sorry about this, but it's true.
We didn't intentionally sit the two of you next to each other.
No, I love this because I don't think we
Okay,
will talk
so
about
it'll have gag orders to not reveal prices, which we know is against the law and No Surprises Act. And then the second thing it'll have is it'll say we get to keep 30%, 28%, but let's round up to 30, 28% of the delta of the share of the savings we got you, Mr. or Mrs. Employer, from that funny number. So if you all read your employer's contracts with the carriers, you're going to understand why healthcare, because the higher the prices and the higher that delta, the more money everyone makes in the system. And I'm going to tell you, we're at a point where the war games are enough. It's war games using AI with the insurance industry and the hospital industry and sometimes there's 24 middle players and intermediaries in between, right? And everybody's capitalizing on that patient encounter to make as much money in your revenue cycle optimization as you can. And I'm going to tell you, we are at a crisis tipping point. We are in an absolute tipping point because people are so fearful that they don't get the care they need. They do not get the care they need when they need it for fear of absolute financial ruin, because how many of us raised our hands? And when young people, this is also last night, okay? So I'm like, wow. This is huge. Addiction therapy, a woman came to me who the psych hospital makes her prepay $60,000, but she's totally covered by her insurance carrier in their clause. So she knows she's going to get reimbursed, but she only got reimbursed $19,000. So they had to deplete their retirement funds, she and her husband, and get a second mortgage on their house to pay for their son's addiction care. Now, he is 29 years old. He's an adult. He was on a separate plan. Why are they fiscally responsible? And it turns out when we looked into the billing, both a hospital and they violated on the coding, and she was just reimbursed in full yesterday by the insurance carrier. So we wouldn't need to be involved to do this. We do this complimentary. I beg any of you, please do send it. We'll keep fighting. But we don't need to be this way. We are at a tipping point where those war games are only crushing the patient and their families. And we're at a point where every one of us has the opportunity to pull to our moral compass, and you guys are brilliant. All of you are the most brilliant. And we can cut out the intermediaries. Because, look, I just tore my meniscus in Washington Ice a couple weeks ago, in a couple places, and I ended up in the ER. Last place I want to be ER. My copay was $2,000 estimate for 20% with my employer. Well, we own the company, so that's $8,000 to the company, $2,000 to me, saying that my card made me charge more. I looked at the billing officer and I said, this is just to be in the room, right? I haven't gotten any care yet. This is just to be in the room, $10,000. What's the cash price? $719.65 for payment in full. I took the cash price. But the reality is how many people know to ask?
Right.
So where is the value in that? Where is the value in the coverage? If my husband's going to owe me it's his company, so it's going to really owe me a nice Valentine's Day dinner with my savings. But the reality is where is the value? We've lost our way. Where is the value? Because that's no negotiating leverage. And look, physicians complain that they don't get paid for 3 and 8 months afterwards. They could be paid right away if we clean out all the middle players and everybody runs on it as a cost center and knows what margin is fair. So go to that cost plus model and get rid of all the unnecessary intermediaries as fast as we can, and we can be the most competitive country and allow our companies to be competitive and allow our futures and our children and our grandchildren to have a future, healthier, longer lives at a far lower cost.
Thanks. I'm gonna let Jocelyn and Colin buffer a little bit.
Yeah, and I think I'm here for a reason, right? I made the switch to be inside of a health plan for a reason, and I chose to be at Aetna because I've had experience in working with a lot of different organizations. And I use the word moral imperative, I think it's important. Like, the work that we do is so incredibly important, and there is inefficiency and waste. And so one of the things that we've been doing from a team perspective, my small but mighty interoperability team within Aetna is really changing the way that we're showing up to talk to providers in those conversations, is really making sure that we're taking that technology-first approach and the way we're doing things. I sit inside of a provider experience team inside of Aetna. The person that recruited me knew she needed somebody from the outside to come in and sort of open up that world a little bit more. But alongside that, she owns the teams that are also dealing with some of those challenges that you're talking about. Provider data in itself, I'm sure, has a sweet spot and a moment of affection for everyone in the room. But the idea that the tools are here, listening to you and Colin speak, I have a real-time benefit check API that we put out last year, and Ryan Howells and I were talking about it yesterday. Nobody's come knocking on my door to use it. It's live, it's available, the information's there. I actually own the MRF team, the machine readable file team, under my purview. I own all of the compliance projects for Aetna around interoperability. And I'm the person who signs the attestation that we don't have gag clauses in our network contracts. And I'm disappointed to hear that you're still up against that, but that could be legacy, things going through the legal system. But, there's active NPRMs out about MRF, so I'm not going to say anything publicly about maybe some of the limitations of the current structure of that data. But I think that if we're really going to solve the problem, we need to get to the real-time information in workflow so people really understand what their cost is. I do think, this momentum and the way we're changing the way we talk to providers about how to use the tools to get to better transparency, it's not going to fix the mismatch, right? I like the way that I'm not going to use the phrasing that you used, but I think that we're walking into conversations with providers today to say about how can we, and my GA person's going to yell at me, I use the phrase internally, take the sock out of the process for folks, right? Because there are things that there's an insanity about how things have gotten to be where they are and what can we do with technology, right? Understanding that we are in the business of simplifying, right, and getting care to people, improving their outcomes. But how can we leverage technology like every other industry has to create that opportunity to innovate and to do things differently? And I really believe that the people that are the most successful picking up the tools that are available, because they're there, and find the partners to do that work, are the folks that are going to help transform to that next experience that we have within healthcare. And you have to have a willingness, right? I'm surrounded by people in industry and inside my organization that really understand that we have to be that change, that the status quo isn't acceptable, and that it is about our members and our patients really being able to get the care they need when they want to be able to get it, and that they can do it in a fully informed way that isn't going to bankrupt them or end up with a surprise bill. So
I got something for you. How about, I mean, we know through the No Surprises Act 5 years ago, we were supposed to have the advanced EOB, which is prices first healthcare, before January 1st, 2022. We're looking forward to this administration that's committed to getting that out there. But you don't need government to do that. No, you could do that now. You could give the prices first, advanced EOB, which is then also automatically a pre-authorization. Here's the pre-auth. This is what your share is going to be of pay, and this is this. This is what you're going to pay. And then you could have an itemized bill, and you could also release the payment that's shared with the employer to have integrity to that advanced EOB, and just do it.
Can I get a show of hands? Is there anybody in here that uses their Aetna Health app? Because we do all of that today. That we've made massive investments over the last 4 or 5 years for that transparency.
Estimate or actual?
We give an estimate today, but
I want actual.
But my team is actually, yeah. But the reality is because it's not regulated, and there is lots of politics around the landscape. Period.
Yeah, but you could have first mover advantage.
So my team is actively testing the patient cost transparency API. That's a FHIR standard. That's the equivalent of real-time benefit check paired with the coverage requirements discovery. I'm going to nerd out here for a minute to essentially get the equivalent of a real-time benefit tool for a consumer. We are driving that conversation in industry, literally with 3 other players, and no one else is coming to play because it's not being regulated, because a rule hasn't dropped. And so you're right, we have to be bold. One of my team members is presenting on PCT is the name of the IG, if people aren't paying attention, patient cost transparency, at HIMSS with the Da Vinci team, because we're actively testing with our vendor and with other players in the market so that should be a reality.
All right. I'm going to pitch the rights to the Cynthia and Jocelyn podcast later.
I mean,
Stay tuned.
We have to fix it.
Stay tuned.
We have to fix it.
Sumit, part of as we were listening to this conversation is like, where do we go from here? The cost sensitivities that are involved, the affordability issues that patients face. What are you seeing from your perspective?
Well, look, firstly, your words and your passion, that's probably the best vision statement for why so many of us wake up every morning and get to work, because these are the problems to be solved. And having said that, just even the letter that we heard in the keynote, not probably very few people in the audience don't have some experience like that to talk about, or many. And it's been years. It's been decades. And so, yes, we're making progress. Yes, we're starting or already sharing stuff. And yes, we're implementing technologies that comply with what we're supposed to be doing. And yet, we all recognize that if this were any other industry with a free market where consumers were the ultimate buyers and they could go buy from whoever they wanted, that this industry would not exist as it does. And your point about cost plus was just a really great example of what we're talking about when we say health model. So the word insanity was used a few times, right? And ultimately, I've been told this in my career as well, that the definition of insanity is to do the same thing over and over again and expect a different outcome. Well, we've been doing that in this industry, and we're still doing that. And I don't think that that's how we're going to go solve, ultimately, the friction, because no matter what we do, it's still working for the parties that we're trying to solve it with. The friction still works for them. And so really, the solution to this is not going to come from inside. It's going to come from competition. It's going to come from new players. And it's going to come from consumers actually being able to make those choices because those new players have emerged. I just don't see how 30 years in, there's going to be a different outcome unless there's a fundamental change like that.
Yeah. And so, Colin, help connect the dots, or maybe across the kind of medication transaction flow, for the real-time prescription benefit, prior authorization as it fits in, and what the clinical workflow looks like relative to the patient dynamic. I mean, Tom gave a great example during the keynote. I raised my hand earlier, Cynthia. It says, like, I show up at the pharmacy, and we had a discussion about what I was supposed to get, and then I go there, and I have great insurance from the federal government, and it was still like several hundreds of dollars. And I'm like, nope. So how do we get the education and literacy part into that conversation?
Yeah, it's funny because when that happens and you don't pick that medication up, like I don't find out until the next visit 6 months later, and now I've lost 6 months, a year of cholesterol, whatever. The best decision support is, I would say, the right at the right moment and not necessarily intrusive. Different providers want their decision support in different ways. Just like we all prefer to get our communications different ways. Some of us like text, some of us like email, some of us, look at Twitter or X, whatever we want to call it. So we need to be very thoughtful on how we implement these interventions. I would say the best prior authorization is one that I never have to do. And we can be smart enough to nudge the provider to provide extra context in the middle of that prescription conversation and transaction to say, you know what, if you just add a diagnosis code here, chances are you're gonna skip the PA or you're gonna jumpstart it and save a couple weeks. But the doctors, sometimes we feel like we're playing a game that we don't know the rules to. And the rules vary across payers and patients, et cetera, et cetera. And so I do have great hope for AI to help in this capacity. I've been doing informatics for 20 plus years. I've never seen anything adopted at this rate. I've never seen providers actually ask for something technology related. The EHR was kicking and screaming, and now ambient scribing and all of these other things are table stakes. It's not even like novel anymore. And so in order to empower the patient and the provider, we're going to just keep coming back to that transparency. You need to be transparent, and it needs to be in the right moment, in the right workflow. Because what we're doing now is kind of, it's still antiquated. We've had e-prescribing for 20 years. Like, you can read my handwriting now good. I get some drug-drug interactions and maybe some other benefits along the way, but it's still a very, fire and forget, ping pong because you need to change this. Oh, I need to get the pharmacist. Come on, 25 years later, we could do better. And that's what I take pride in working on with Dr. First. And so transparency within workflow, all of those things that we've been hammering home for so long. But I do think we're at this inflection point for technology. I think we're ready to embrace it.
Yeah.
As I was listening to this conversation, I was reminded of a moment. Part of my career, I've spent a lot of time in the UK working with the NHS there as well. And maybe 20 years ago, about that time frame, I was in a meeting, in a presentation in Leeds, where I had just given a vision for data interoperability and how information across that entire city region could be pulled together. And then somebody else got up and started describing how they were going to, over the next 10 years, follow a path to cause that to happen. And it was all about some of the same standards that had to be developed, and they talked about all the same stuff that we've all then lived through over the past, that same period. And I remember this moment where somebody in the audience, who over time became a really great friend, got up, he worked for the NHS, and he said, "That's just a really great vision. Who is going to care for my parents now?" Right? And I think that's what it boils down to. What you're hearing from me here is, yes, these are all important steps along the way, but that word, the momentum, and actually the speed, that's what we're all missing. And that was the point that gentleman made, and I think today we're still looking for that speed. What about us today? When are we going to go solve this, right? And we don't think that the medical model alone can do that anymore. And we also believe that because of the changes that are happening, because of both entrepreneurs coming in, and because of changes in regulations that are emerging, that are opening opportunities, that these experiments are now not just being tried, but they're now starting to scale. And so the health model is key to addressing many of the topics we're talking about here.
Yeah.
It'll build on the same stuff, but it'll operate at a different pace.
Yeah. Jocelyn?
Yeah, this is where my inner recovering product manager comes in. What Samit is describing, right, is the impatience, right? We all need to be impatient. But this idea of incrementalism, right? And I think often we expect technology to solve all of the problems, and we never account for, and I'll use an example of prior authorization, the knowledge that is in that workers, that nurse that's doing PAs all day long in a back office for pharmacy 10 years ago, all of the nuance and understanding that that person had and the little side workflows, you have to grow into that to get to a fully digital experience. And I think on the pharmacy prior auth side, we're there. I helped bring the pharmacy prior auth standard live a decade ago with our friends at Cover My Meds when I was at Navinet. And day one, getting people to use it, there wasn't enough full functionality, right? And so if we think about this progression and technology being an enabler, I'll use a more recent Aetna example. We've struggled to digitize our facilities that aren't hospitals, right? We think about our SNFs and long-term care. I did some work in that before I joined Aetna, and we have a digital desert there. And so we're doing things like creating better connections, getting more connectivity with those facilities, right? But the reality is people are still showing up in an ambulance with their records pinned to them, right, when they're in a transition of care. We have financial incentives and provider or member experience incentives to improve those processes. So while we're alongside trying to improve the digital footprint, my Med Affairs team and my clinicians inside of Aetna are physically putting nurses into hospital settings to provide that bridge, that human connectedness, to be able to, we sort of do this, everything that's old is new again, right? We're using the human to bridge where the technology isn't there yet. And it has to be, technology has to be enabler. It's not the answer. And I think that doing this work to really understand what those bigger pain points are the thing that's going to get us to the today solution, even if it is a more human intensive, not permanent, but it's going to allow us to get to that incremental path. Because the reality is the plumbing and the bits and the pieces is really complicated, but we can abstract for all of the users of the system from that if we're really smart and thoughtful about what that entire experience is like, and not just thinking we're going to deploy tech and that's going to fix the problem for us.
So we're getting close to time. Covered a lot. I think some of the warts and all of the healthcare experiences today. We'll transition a little bit to more perhaps the optimism that we've got. The team knows I like to go on metaphorical journeys. So like the one I have here that I was thinking about this morning is you have the movie scene or a show, favorite character, they get knocked off or fall off some type of thing, and you just get the director's cut of a hand and a backdrop. And then the crescendo of music, and someone grabs them. And is that the technology moment that we're at right now? Is the automation there? Is the AI there? Should we be as optimistic as we are? Is the hype real, in terms of the hand grabbing back and catching us?
Did you watch Stranger Things?
That was one of my recent examples. I didn't want to We have pop culture quizzes for some of the staff around town. What do you think, Cynthia?
Well, right now AI and those hands are behind the curtain of obfuscation. And again, it's war games between the insurance carriers and all their intermediaries capitalizing on the patient's misfortune, as well as the hospital, to charge as much as they possibly can and profit as much as they possibly can. When we win is when that's all pulled back and it's done transparently. And so in front of the consumer, in front of seeing all the prices, itemized bills, and payment integrity. And then we can restore trust in our healthcare system. And so, look, this happened in property and casualty in the early 80s. I remember because I was an IBMer then, and I was in those meetings, where it goes to standards. And thank you, Steve, for what your organization does.
Yeah.
Is we could have one standard contract for all providers between the insurance carriers and the hospitals that they use, and then transparently post what are those negotiated rates, what are the outliers, what are the stop loss, what is the entire formula for coding that is standard, and then compare that and let the tech world then develop wonderful tools. So come up with a standard. The other thing is on claims payment and in billing coding. Once standards, agree upon standards, not have Aetna have its own or Cigna have its own or United, and then be complete. Show that 835 data, the 837 data, show the entire, what amount was billed, what was paid to provider, when was it paid to the provider, and who got what on the intermediaries. And then let us as CEOs and CFOs as employers and unions be able to say, no, I'm not going to give the broker $10 for every prescription that gets converted to a 90-day fill. What value do they add to the equation? When Mark Cuban can do cost plus 15% plus shipping at $28.40 versus over $10,300 for the same MS drug, we have the opportunity to do the right thing by the consumer. And yes, it will disintermediate. It will disintermediate all the unnecessary players. But therein lies the opportunity for incredible innovation, incredible great improvements in health and outcomes, and to be able to unleash not only competition in price, but quality. And outcomes are really, really important. And I'm going to say that every single one of you went into healthcare. I did as well. We all went into healthcare to live the ideal to do better for our fellow citizens. And we can all do better. So I would just encourage the inner compass, the moral compass, as you say, but we know we can go faster. We know we can do so much better. And I respect that, God willing, we'll all live longer lives, but 30 years from now, I don't want to be on this stage still talking about interoperability. So the reality is we can do better now, and this industry needs huge disruption. Why? And again, go home and ask for your employer to show you that contract. Why should a preferred provider that is revealed in the contract that the insurance carrier may own that preferred provider be able to charge more and the insurance carrier participate in those profits, and also put clauses in that say, and their billing may not be audited or overseen. And if the carrier as a third party made a mistake and paid that OB $100,000 or the hospital versus $10,000 for that childbirth, they get to keep 50% of the recovery of their own mistake. Okay, is that profits over patients? That means there's an incentive right now in those contracts to make mistakes and overpay. And then finally, I also say drug pricing. Why in the transparency and coverage files do we have drugs that are standardly given in milligrams converted to milliliters that actually could add extra zeros in the pricing? And so we would be killing patients if we were we're not doing the actual standard format of units. I mean, you've probably seen this too, Colin. Let's do standards. Let's put it all out there transparently and let the games begin on providing the best health care at the best possible price, and get rid of all the administrators. They'll get other jobs. My mother was a travel agent. she played, she went and became a really good golfer. Really, we don't need travel agents. We don't need all these administrators.
And scene. Okay.
Exactly.
We're at time. We could have done this all morning. When you create a panel and you bring up a bunch of folks that haven't normally interacted with each other, you always focus on chemistry. And so please give everybody a round of applause for keeping us entertained. Thank you so much. All right. We're all good? Thank you so much.
Thank you. Thank you, Jocelyn. We're happy to work with you guys.
We're at a break. Yes.